Okay, so hi everyone. My name is Carolyn. So I'm going to be talking to you today about the bread and butter of geriatrics, and I got some input from Dr. Arbor, who was a Geri Psych fellow not too long ago, about what might be interesting for you guys. So the objectives today are going to be to talk a little bit about the Canadian demographic information pertaining to the elderly population, which you've certainly heard in previous talks, and understand the role of a geriatrician and the presentation and management of common geriatric syndromes. And these are the main ones that we're going to focus on today. Just of note that dementia and delirium makes up a large part of what we do as well, but that's already been covered for you elsewhere, as far as I understand, so we won't talk about that today. So just by way of introduction, as you're probably aware, the average age in Canada has been steadily getting higher and higher, and currently already the average age is older, especially sort of the most western and eastern provinces, with an increasing number of centenarians, and the number of persons aged 15 to 64 per person aged 65 and older has been steadily declining since 1980. So we're already facing an aging population. And this is only expected to increase with numbers projected by 2041 to show around 25% of the population falling under the elderly range, and 6% of the population being 85 years old and older. So it's becoming increasingly important that we know how to care for the elderly population as best we can. And so when we say the geriatric population, in general, we're talking about 65 years old and older. For geriatricians, though, it will really depend on where you are in Canada and which university site you're at. And in some university hospitals, geriatricians will see more the 75 years old and older or 85 years old and older. And the sort of younger end of that spectrum is more internal medicine. But in general, 65 years old and older. And by the Royal College of Physicians, geriatric medicine is the branch of medicine concerned with the prevention, diagnosis, treatment, and social aspects of illness in older adults. So what we do is a comprehensive geriatric assessment. And what that basically means is going through the same sort of headers that are included in psych consults, internal medicine consults, so the things like past medical history, medications, habits, allergies, etc. But we also do something called a geriatric review of systems, or at least that's what it's called at McGill, which goes through these main topics. So we go much more in depth into the social background than an internal medicine consult would. And I'm sure you guys also go in depth into the social background. But focusing on education in the past, family, specifically what family support they have around them in the city that they're living in, what they did previously for work, and where they're currently living, and always inquire, are there any public or private nursing or PAB services that are involved in their care? We review, obviously, IADLs and ADLs, and if they're managing that alone or with the help of someone else. We ask pretty detailed questions about their mobility, which can include, do they feel steady when they walk, or do they feel unsteady? Do they worry about falling when they walk? How active they are? Do they do exercise? Do they go outside walking? Do they use gait aids? And if they're supposed to be using them, are they compliant? Have there been any previous falls? And we always try to sort of understand the circumstances around the fall, which we'll talk about a bit later. We sort of inquire into mind and mood, which we won't go into detail on in this presentation. We ask them about sleep, so their sleep quality, how many hours they're sleeping, trying to determine if there's underlying insomnia, but also questions pertaining to sleep apnea, REM sleep behavior disorder, and whether they're sleeping quite a lot during the day, because that will affect how functional they'll be and their ability to sort of interact and have a good quality of life. We ask questions regarding incontinence of stool or urine and whether there's constipation, and we go into questioning about their hearing and vision. And often, at least for hearing, we'll ask family members if they've perceived any impairments in hearing, and if they have hearing aids, do they work, are they compliant? Or for vision problems, when's the last time they had a checkup? And then we'll also ask about nutrition. So what are daily meals for them? What do they look like? Is their appetite good? Has the family perceived any weight loss? And try to get a sense if they're taking in enough nutrition. And we put all of those geriatric review system topics and all the past medical history and meds, et cetera, all together and create an impression and plan that consists of the 5 M's. So the first M is mind, and pretty straightforward. We comment on whether there's a major or minor neurocognitive disorder, whether there's delirium, if there's any underlying mood issues. We comment on, for mobility, any falls history. And specifically, if somebody's coming in for a fall and you're doing this consult for a fall, you'll comment on any factors that might have contributed to that fall or led to the fall, their overall risk of falls, if there's any gait impairment, if they should be using mobility aids. Then we'll do a review of medications, which will look at the appropriateness of each medication they're on, try to reduce polypharmacy, add any missing medications based on comorbidity, and also assess, calculated GFR, look at their liver function and assess medications based on that. For morbidity, the 4th M will list out every comorbidity the patient is known for and any additional ones we're diagnosing them with on this assessment, and comment on the stability of each one and if any further investigations or management is warranted. And the last M is matters most, which is sort of the big picture in this case. What is their overall goal of care? Where should they be going after this? What is their disposition? How can we optimize their function and quality of life? So that's a little bit of how we do the comprehensive geriatric assessment. And there's evidence for it in a variety of different settings. So in non-orthopedic surgery admission can result in reducing delirium and length of stay. For traumatic hip fracture, reducing delirium, mobility decline, mortality and disability in ADLs. If patients are admitted for acute medical conditions, it can hopefully prevent transfers to nursing homes at discharge and can reduce risk of physical frailty in community dwelling older adults. So don't hesitate to get us involved to do a comprehensive geriatric assessment in any setting. So the first geriatric syndrome we're going to talk about is falls. And I think the main sort of takeaway and main point of this is that falls are a much bigger problem than most of us probably realize. This data comes from the Stopping Elderly Accidents, Death and Injury Initiative by the CDC. I encourage you, if you're interested more into falls, to look at this initiative. If you Google it as part of the CDC, it provides a lot of handouts and trainings with regards to fall. But just to highlight, 1 in 4 people 65 and older falls each year, and every 20 minutes an older adult dies from a fall. Serious injury from a fall, it occurs quite commonly. There's a lot of costs in the ER. And overall, it's a big problem. And so preventing it has become quite important. And multifactorial approaches to preventing falls have are quite effective. So a little bit about the risk factors for fall. There are a long list. Whoops, this is not exhaustive, but these are some of the main ones that I wanted to highlight that will be interesting for you. So obviously benzos being a very important risk factor with a positive likelihood ratio of 27. So just to always keep that in mind when prescribing benzos, that along with all the other risks comes with a significant risk of fall. And dementia in itself is a significant risk factor, previous stroke on exam, Parkinson's. If you have to use your arms to rise from a chair using the armrest, it suggests lower extremity proximal muscle weakness and an increased risk of falls. Previous fall is a risk factor, and not unsurprisingly, polypharmacy and psychotropic medications. So many risk factors that all work together to increase the risk of falls. And so how you can screen somebody for a risk of falls these are the 3 main ways it can be done. And these are for community dwelling older adults. So you can ask them, have you fallen in the past 12 months? And it's pretty specific, but not very sensitive. So to increase the sensitivity, you can do the 3 key questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Do you worry about falling? And yes to any one of these is associated with an increased risk of fall. There's also the STAY independent self-risk assessment that you can get on the study website if you're interested, and patients can go through that themselves and it can assess risk. So why that's important is that there were World Falls Initiative guidelines published in 2022 that has been talked a lot in geriatrics. And this is sort of a snapshot of the algorithm in the guidelines. And as geri psych, you'll probably be falling more on the left side, which is seeing a patient for an unrelated reason, just for a health visit. And if you want to assess the risk of falls, you might ask them, have they fallen in the past 12 months, or the 3 key questions. And then depending if they say yes or no, they'll fall into a different risk category. So if they say no, then the risk is still, they fall under low risk, where primary prevention becomes important. Because if you see here at the top in blue, there's still a 30% risk of 1 or more fall in the next year. So still a considerable risk. And so how we manage these patients is through exercise, education, falls prevention, and fracture risk assessment. So the exercise recommendations for these patients would be 150 to 300 minutes per week of intermediate intensity, or 75 to 150 of vigorous intensity aerobic exercise. And they should be doing muscle strengthening exercises at least 2 or more days of the week. And incorporated within all of that should be a focus on balance and strength training. So balance and strength training exercise would be, for example, practicing sitting to standing, squats, standing with a narrow base of support, making them walk in different directions while they're multitasking or in different environments, all to sort of develop balance. Tai Chi is also another important and good recommendation for balance training. And then they should be having a fracture risk assessment, meaning should they be getting a bone mineral density screening for osteoporosis? What is their frac score and osteoporosis risk? Should they be treated for osteoporosis? And their primary care provider can probably look into that. And then falls prevention really applies to anyone who's in the older age group. And that constitutes exercise, as we already discussed, but also reviewing medications to see if we can optimize and reduce or remove anything that increases the risk of falls, which we'll talk about. The presence of home hazards. So that's a big one. I think it's often forgotten. Usually OTs can help with that, but there's also home safety checklists available on Study if you're ever interested. Don't forget to ask about vision concerns and whether they should be due for another follow-up with an ophthalmologist or optometrist if they're known for eye issues. Feet and footwear. All patients should have their feet examined as part of falls prevention and falls management. And if there's any, bunions or sores or ingrown toenails, etc., then referral to a podiatrist becomes important. But one simple thing that we can all do, and if you see people on, let's say, a psychiatric ward walking around, what shoes are they wearing? Because as part of falls prevention, the recommendation is that all older adults try to wear low heel shoes with a slip resistant firm sole, and the shoe should be closed, and they should be wearing that both inside and outside the house in order to prevent falls as much as possible. And if there is vitamin D deficiency, they should have vitamin D supplementation. In general, because vitamin D is such a benign sort of supplementation, most older adults will be prescribed it by their primary care providers or by geriatricians without necessarily checking a level. So vitamin D is also important. But there's also the right side of the algorithm, which is people presenting for a fall, or let's say they say yes to a fall within the last 12 months. Then it becomes necessary to assess the fall severity. So that's looking into whether they had an injury from a previous fall, if they had 2 or more falls in the last year, if they had a long lie on the floor, if there's suspicion of a syncope causing the fall, meaning multiple unwitnessed falls, there's no clear explanation for why it happened, there's a loss of consciousness. If there are any factors such as these, then they fall under high risk. And now we're talking more secondary prevention and treatment. And how we deal with those patients is by doing something called a multifactorial falls risk assessment, and then individualizing our interventions based on that. So these are the components of a multifactorial falls risk assessment. Basically, the takeaway here is that there's, as we mentioned, there's multiple risk factors for falls. We're trying to identify which ones are at play and optimize them as much as possible. And it's by doing all of this and considering it multifactorial that will have the most benefit in terms of preventing further falls. One individual intervention will likely not have much of a benefit. So a lot of these are pretty self-explanatory. You go through the activities of daily living, cognition, as we said, dementia is a risk factor, but specifically issues with executive dysfunction can play a major role. You can review medications with a tool called Stop Fall, which we'll talk about a little later with polypharmacy. Their disease history, because a lot of diseases can contribute to falls if poorly controlled. You might ask about their nutrition or assess their nutrition. There's something called the mini nutritional assessment, which you can find online, which is a good questionnaire that can help sort of guide you in terms of assessing nutrition. And vitamin D supplementation also falls under nutrition. And then in terms of environmental risk, that's really going through the extrinsic factors like any rugs that might cause them to slip, obstacles in the home, dim lighting, etc. So we as geriatricians will sort of go through all of these domains. And just to talk about them in a little bit more detail, when we talk about mobility in falls clinics and outpatient geriatric day hospitals, we'll do a lot of maneuvers, such as the gait speed and the timed up and go, which I included diagrams. You don't really have to know the details, but basically if you have a slow gait speed, or a slow timed up and go, which means it takes you more than 15 seconds to get up from a chair, walk 3 meters, turn around and sit back down. Those maneuvers are associated with increased risk of fall. Physio can also, if you're ever concerned that a patient might have some balance issues, you can refer them to physio and they'll do certain maneuvers to assess that. And we also go through muscle strength just by assessing how often they can stand and sit back down in a chair without using their arms in 30 seconds, as well as do individual power exam for each muscle group. We'll look at their walking aids, their footwear and foot problems, and assess fear of falling. And so all of this falls under the mobility domain as part of the multifactorial falls risk assessment. And just to review, the appropriate use of a gait aid, if you ever see somebody walking around with a cane or a walker and you're not sure, is this the right height? A cane, if appropriately measured, should go up to the crease of the wrist when the hand or the arm is just sort of relaxed to the side, so that when they're holding it, the elbow is flexed about 15 degrees. And same for the walker, it should be about a 15-degree flexion in the elbow when they're holding it. The other domain I wanted to talk about is autonomic function, which refers to looking into orthostatic hypotension or urinary incontinence, because orthostatic hypotension, I think you guys probably encounter this in the context of a lot of the medications you use, or Parkinsonism. So how we diagnose that is by having the patient supine for at least 5 minutes before taking their blood pressure supine, and then when they stand, at 1 minute and at 3 minutes, and you're looking for a drop in systolic blood pressure of 20 or more, or diastolic of 10 or more. And that's diagnostic for orthostatic hypotension. And so if you find that, then it becomes important to review the medication. So for any sort of anticholinergic medications, antipsychotics, but also diuretics, blood pressure medications. Also look into if they're hydrating adequately and taking in enough salt, if their cardiac status allows for it. And if all of those things have been optimized as much as possible and they're still having orthostatic symptoms and proven orthostatic hypotension, then we sort of go into, I have the diagram here on the right, compressive garments and compressant stockings that should go up to the waist in order to be effective. So just keep that in mind. It's not very comfortable. We recommend that they sleep with the head of the bed elevated. That can also help with the symptoms. And then you're going into medications like Midodrine or Florinef, etc. And urinary incontinence is also an increased risk of falls, and we'll talk about that a bit later. So what do we do for these high-risk patients? We recommend exercise, the same recommendation for the low-risk patients, and we want to prevent long lies on the floor, which means that it takes them a really long time to get up. because that's associated with urinary tract infections, pneumonia, electrolyte abnormalities. So oftentimes you can organize for them to get wrist alarms or fall detectors, or that they carry mobile telephones so that they can call somebody if they do fall. And a lot of outpatient geriatric rehabs with the physio will teach them how to get up from the floor in case they do fall, which I've outlined for you here on the right. And it's really just broken down into steps so that they can get to a chair and sit back down. And then you have to target the multifactorial falls risk assessment. So all these domains you've reviewed looking for any abnormalities. So for mobility, it's really just exercise and gait aids and looking at the feet. For sensory, it's vision and hearing, making sure they see optometrists or audiologists if necessary, but also asking about vertigo and managing the vertigo if it's present, usually with an ENT referral. For activities of daily living, usually an OT can help optimize that with equipment if necessary. For cognition, there's not really more recommendation than how we usually manage it. For medications, we suggest deprescribing if possible, and we'll talk about the medications to target. For disease history, it's really just about optimizing all their comorbidities if possible, but specifically whether or not there might be an underlying arrhythmia causing the falls. So as I mentioned, syncope would be recurrent unexplained falls or loss of consciousness. Then that might warrant a cardiology consult for a pacemaker and optimizing their meds. And if there's a significant pain component as part of their disease history, like a lot of arthritis in the knees, because that's also a risk factor for falls, optimizing pain as much as possible with like Tylenol, Voltaren gel, and avoiding opioids, because opioids can cause falls. Autonomic function will be managing orthostatic hypotension and urinary incontinence. And then we optimize nutrition, add vitamin D, and have them see OT to optimize their environment. So it's a lot of things, a very long assessment for falls, but that's pretty much falls in a nutshell. And now we'll talk about polypharmacy. So essentially, I think you're all familiar with what polypharmacy is. The most commonly used threshold is 5 or more drugs. And part of polypharmacy is both inappropriate and appropriate prescribing. So inappropriate refers to medications where the risk outweighs the benefit, especially if there's other drugs, alternatives available. And both inappropriate prescribing and polypharmacy can increase the risk of adverse drug reactions. And unsurprisingly, older age is a risk factor for polypharmacy, as well as sort of inpatient settings more than outpatient settings. So adverse drug reactions, you probably heard about these before, but I think the key thing to highlight here is that in the elderly, it can look sort of non-specific with falls. We talked about fatigue, cognitive decline, and constipation, and lead to prescribing cascades, which basically means that you prescribe something, there's a side effect, and so more medications are prescribed to treat the side effect. And adverse drug reactions can happen more commonly in the elderly because of pharmacokinetic and pharmacodynamic changes that occur, specifically a decrease in muscle mass and water content, and an increase in the proportion of total body fat. So if I use benzos, for example, which is lipophilic, in the elderly, there would be a higher volume of distribution and a prolonged half-life, and then accumulation of this drug. So that's why they're going with small doses and going slowly becomes important. So these are the main tools that we use to assess polypharmacy, which are probably familiar to you. Stop-start, I have to say, is not super used at McGill compared to Beers, but it is more comprehensive than the Beers criteria because it includes not only guidelines or suggestions for inappropriate medications, but also potential prescribing omissions, and has around 114 criteria, 80 stop and 34 criteria or medication classes you should consider starting, and is separated by physiologic system. And I included the website for you to access the whole PDF with all these recommendations in the bottom left. But for example, if you go to nervous system, which is chapter 4, and look at tricyclics, it'll tell you specifically when to stop them. So for example, patients with dementia due to the risk of worsening cognitive impairment. So this can be a pretty comprehensive guide for looking at medications. Stop fall is what's recommended as part of the medication assessment in falls. It's basically a consensus group that came up with these drug classes that increase the risk of falls, and I think a lot of them are not particularly surprising. So benzos, antipsychotics, and antidepressants, which are used a lot by you guys, but also things like vasodilators, like isosorbide mononitrate, and medications for overactive bladder, like oxybutynin. So you can take a look at this list. And if you look at Stop Fall online, it also includes recommendations for each drug class about when to consider withdrawing it. So for example, benzos, if there's daytime sedation, cognitive impairment, or psychomotor impairments, how quickly to withdraw it, and what to monitor for once you deprescribe it. And there's also, I included here a website at the bottom, which are decision trees from Stop Fall for each medication class to help you decide, okay, is the benefit of deprescribing outweighing the risk in my patient? And then finally, there's the Beers criteria, which I think you're familiar with, which includes multiple drug classes, and then also different syndromes with medications to avoid for each one. So for example, they say benzos are appropriate for REM sleep behavior disorder, seizure disorder, benzo withdrawal, alcohol withdrawal, severe GAD, and peri-procedural anesthesia, but should be avoided in other cases due to all the risks that we know. And they also have recommendations for antipsychotics. And then it also includes recommendations based on the syndrome, like I said. So for falls, they focus mainly on anti-epileptics, antipsychotic, and benzos. And so their list is a lot less long or a lot less comprehensive than Stop Fall, for example. So that is usually what we use for polypharmacy. We'll talk about incontinence now. And so what incontinence really means is the involuntary leaking of urine. And continence, on the other side, means being able to go to the bathroom when and where you want, and being able to control and choose when you go. It's more common in older women, and it has a high prevalence in nursing homes, but is also quite common in community dwelling older adults. And it's important because it can result in falls, UTI, and isolation. And a lot of the times patients will avoid leaving the house because of the stigma surrounding incontinence. And I think the key point for incontinence is that many individuals won't bring it up to you. It's going to be something that they're a lot of the times ashamed of. And so you sort of have to specifically go out of your way to ask about it. And the ways that are sort of recommended to ask about it is, tell me about any problems you're having holding your urine. How often do you leak your urine throughout the day? Do you wear protective pads or devices to collect urine because you're having trouble without them? Those might be some ways to go about asking it. So there are 5 main types of incontinence, and it's important to understand each type when you're seeing a patient, because the management will depend on what type of incontinence is at play. So for example, stress incontinence means leaking of urine from a stressor, such as coughing, laughing, sneezing, exercise. And this type of incontinence is much more common in postmenopausal women because it's associated with pelvic floor muscle weakness. So, postmenopause, but multiple vaginal deliveries, if you've had a hysterectomy, obesity, all of these things will contribute to pelvic floor muscle weakness and to possible stress incontinence. And so this is not common in men unless they've had surgeries within the urinary tract that might have disrupted the anatomy and the musculature, then that might be the case. For urgency, what that means is that there's a sudden, uncontrollable feeling that they need to urinate, that they find difficult to delay. And then following this sudden urge is an episode of incontinence or leaking of urine. And this happens usually because of overactivity of the bladder muscle, which can happen with age, but can also happen in the context of neurologic problems with, let's say, damage to the spinal cord or multiple sclerosis, things like that. Or if there's an anatomic obstruction within the urinary tract, it can cause bladder muscle overactivity, trying to sort of get around that obstruction and leaking of urine. So that's urgency. Mixed means both stress and urgency. Functional incontinence means there isn't a problem with the urinary tract itself per se, or the anatomy, but the environment or the function of the person keeps them from making it to the bathroom in time. So you'll often hear of people with mobility problems or gait impairment. They won't be able to get to the bathroom in time, and so they'll have an episode of incontinence, or people who have issues with fine motor movement and can't undo buttons. Then they won't be able to get their clothes off in time, or maybe they need the bathroom adapted in order to sort of to get there in time. So that would be functional incontinence. And then there's high post-void residual, which was previously called overflow incontinence. And that just means pretty self-explanatory. There's an obstruction causing a lot of retention, and then the urine sort of overflows around the obstruction. And really the most common cause of that is probably BPH in men. There's also this concept of overactive bladder, which is the symptom of urgency with that sudden uncontrollable urge to urinate, with nonspecific lower urinary tract symptoms like frequency, which is usually defined as urinating 7 or more times per day, or nocturia, which is waking up to urinate 2 or more times in a night. And that might be associated with incontinence, or it might not be. They might just have these urinary symptoms. And overactive bladder is treated similarly to urge incontinence. So another really important point for you guys in terms of urinary incontinence is medications, and that medications can cause these symptoms. So there's obviously things like diuretics that will cause polyuria, or any medication that causes peripheral edema will result in reabsorption, usually at night. So medications like gabapentin, pregabalin can cause peripheral edema, and through that reabsorption at night, they can get nocturia. So I think you guys use those medications, so just to keep that in mind. But for anticholinergics, due to urinary retention and constipation, can cause sort of an overflow picture. And other psychotropic medications through their anticholinergic actions, but also through sort of sedation and affecting mobility. And that can contribute to sort of a functional incontinence picture. And then cholinesterase inhibitors can worsen overactive bladder symptoms with urinary frequency and urgency. So a good review of medications becomes necessary. And then how you would treat each one, again, depends on the type. For urgency incontinence, the emphasis is on lifestyle and behavioral modifications, and possibly drugs if those don't work. For high post-void residual, reviewing the medication, see if there's anything causing retention, treat constipation. For men, you might consider an alpha blocker if there's BPH, and if there's persistent high post-void residual and obstruction, then urology probably has to get involved. And for stress incontinence, it's really lifestyle and behavioral therapies. There's no good medications for that. And if those don't work, then urogyne can see the patient and potentially suggest things like pessaries or other interventions that they do for that. So just quickly on the lifestyle interventions and behavioral interventions, lifestyle interventions really means making sure that they're taking in a good amount of fluid. So not too little, not too much, because too little fluid can actually irritate the urothelium and result in more urinary symptoms. So we usually say about 1.5 to 2 liters per day, including what you consume in food. Managing constipation, looking at medications, but also inquiring into comorbidity, because things like obstructive sleep apnea, which causes a lot of sort of strain on the heart, can release atrial natriuretic peptide and result in nocturia and diuresis. So identifying obstructive sleep apnea if someone's having a lot of nocturia could be important and could go away if you treat the obstructive sleep apnea. If their diabetes is poorly controlled and they have hyperglycemia, they might get polyuria from that. If they have COPD and they're coughing a lot, then it might worsen stress incontinence. So the comorbidity plays a big role. You want to optimize function and maybe adapt the bathroom if necessary. Weight loss is important, especially for stress incontinence, with about 10% of body weight loss being sufficient to sort of help with symptoms, and smoking cessation, because that can also contribute. And behavioral interventions really refers to urge suppression and bladder training in patients who are cognitively intact and able to do that. And what that means is that if somebody's having sudden urge, we teach them how to distract themselves. So either with cognitive exercises like counting the months backwards, or deep breathing, to sort of try to suppress that urge. And then they move on to bladder training, which means once the urge is suppressed, they train themselves to wait longer and longer before going to the bathroom and urinating. So they might start with 5 seconds, then 10 seconds, and then all the way up till 2 minutes from when the urge is suppressed to when they finally urinate. If people don't have the cognitive abilities to do that, then timed voiding and prompted voiding are suggested. Time voiding means bringing them to the bathroom at specific intervals, like maybe every 90 minutes to 2 hours. And prompted voiding usually involves a caregiver looking at the patient and looking for any signs of agitation or discomfort, and then bringing them to the bathroom based on that. And then pelvic floor muscle therapy can be especially beneficial for stress incontinence. So I left the main medications if you're interested in the presentation, if you want to take a look at it. I think just the main thing is that the antimuscarinics are very highly anticholinergic, so we avoid those as much as possible and use beta-3 agonists like mirabegron for urge incontinence, and the side effect there is hypertension. And if you're having a difficulty with a patient who's having a lot of orthostatic hypotension, they're also on an alpha blocker. The ones that give less orthostatic hypotension are alfuzosin, silodosin, and tamsulosin. All right, so now we're going to talk about frailty. So what frailty basically is, by definition, is an increased vulnerability to a stressor event, which increases the risk of adverse outcomes like fall, delirium, and disability. So what this means, and I think it's really well sort of highlighted here on the right in this diagram, but in green, let's say this is somebody who's not frail, they're independent, they're functioning well, they have a minor illness like a urinary tract infection, their functional abilities sort of drop a little bit, but doesn't take very long for it to recover, and they go back to baseline and they sort of go on as they usually do. Whereas someone who's frail, like here in red, they're already sort of on the borderline between independent, dependent. They go through the same minor illness and they take a much bigger hit in terms of functional decline. And it takes them much longer to recuperate, and they never fully recuperate back to their baseline. So that's really what being frail means. And what causes it is kind of complicated. It's a combination of genetic factors, environmental factors, basically leading to issues in different physiologic systems with reduced physiologic reserve in a combination of different systems that all work together to result in frailty or an increased vulnerability to stressors. And then when a stressor event occurs, these patients who are frail are more likely to fall, have delirium, and have impairments in disability or impairments in their function. So the main ways that we assess this, the two main ones that you'll see are the frailty phenotype, which was created by Freed, and includes 5 points that are actually not very easy to sort of gather in an inpatient setting. It's more, you need to be sort of in an outpatient clinic in order to do the frailty phenotype, because you need a dynamometer to assess grip strength. You need enough space so that you can calculate their gait speed. It also includes assessing their energy expenditure, which is not very self-evident. It also includes their self-reported exhaustion and how much weight loss they've had in the past year. And if 3 or more of these are positive, then they're considered frail. So we don't really, at least at McGill, use this as often. We use mainly the clinical frailty scale, which can be identified, or a score can be given just based on the comprehensive geriatric assessment, because it is really based on how functionally dependent they are. So you're living with mild frailty at 5, you're starting to have some issues doing your own IADLs, and then the more IADLs and ADLs you're dependent for, the higher your CFS score becomes. And usually 8 or 7 is the more terminally ill patients. So the CFS score is more commonly used, at least where we're at. And so what you do for frailty, unfortunately, there's not really much at this point other than exercise, which can improve mobility and improve functioning in the frail elderly. And the comprehensive geriatric assessment can also improve outcomes in both community dwelling older adults and on inpatient geriatric floors by improving their physical frailty, but also reducing the likelihood that they will be discharged somewhere other than home. So getting us involved to do a comprehensive geriatric assessment can help. And there's also some evidence for nutrition, and you'll see a lot of geriatricians sort of recommend a high protein diet, which can help with sarcopenia, and then in turn help with frailty. So it's usually nutrition, exercise, and the comprehensive geriatric assessment that are recommended. And so lastly, we'll just talk about elder abuse, which I think in most cases is pretty self-explanatory what they are. Physical and sexual abuse, pretty self-explanatory. Neglect is really when a caregiver or other person fails to provide the necessities of life. Financial abuse, pretty self-explanatory, as well as emotional abuse can look like inflicting mental pain, anguish, distress, and humiliation. And there's this other concept of systemic abuse or institutional abuse, where there are rules or regulations or policies that discriminate against an older adult. And an example of this would be, for example, in the hospital, if someone uses physical restraints on an elderly person to prevent them getting up so that they don't fall, or putting a diaper on someone who's capable of going to the bathroom if they just had a little bit of help, just because there's not enough personnel to manage to bring them to the bathroom. And some signs of abuse. So for physical abuse, the ones that I wanted to really highlight is fracture. Within fractures, the most common one is a humeral fracture, but that can happen from an accident. The fractures that should sort of highlight to you, oh, that's not normal, are jaw, zygomatic, dental fractures, and avulsions of the teeth, because these will be unlikely to be accidental and are more suggestive of physical abuse. And then the usual things like abrasions, lacerations, or bruises. Sexual abuse will be more trauma in the anogenital area or abdomen. Neglect will look a lot like poor hygiene, decubitus ulcers, dehydration, malnutrition. Financial abuse can be a little bit harder, I think, to identify. But it can, some suggestions are looking for inability to pay for necessities, failure to renew prescriptions, worsening medical problems that were previously controlled. And finally, emotional abuse can look like intimidation with the person, the patient referring a lot to the caregiver for answering questions, or somebody who's become quite isolated from friends and family all of a sudden. And then, each province has different helplines for abuse. Becomes a bit complicated in terms of, do they have the capacity to sort of understand what's going on and make decisions against this person or not? But I encourage you to sort of take a look. There's different helplines for elder abuse for each province. I think we're at 45 minutes. That was pretty much everything I had. I don't know if there's any questions.
Thank you for that whirlwind tour of geriatric medicine. I don't know how you did it.
It was very challenging, I think, to summarize it in 45 minutes, but I don't know, hopefully it wasn't information overload.
No, a whole subspecialty. That's impressive. Okay. Anyone have any questions? You can either say them aloud or pop them in the chat. Okay, I'll get started with a question, just hearing none from the residents, and maybe you guys, oh, actually, I see a chat question already. Thank you so much. That was a great review. Okay.
You're welcome.
Yeah, so I'll just ask my question real quick. as a geriatric medicine doctor,
Mhm.
if you were giving advice to a geriatric psychiatrist in a remote area who didn't have access to geriatric medicine and was kind of unsure as to what areas one could delve into, are there any medications you think we might be okay to prescribe? And I'm thinking now things like statins and, blood pressure meds, things like that. I mean, I don't want to take away from your subspecialty because it's so hugely important. And I would say that almost every older adult needs geriatric medicine at some point to live their best life. But, what are we pretty safe to prescribe, in our older adults if we don't have ready access to geriatric medicine?
Yeah, it's a good question because I think in geriatrics, we tend to sort of shy away as much as possible from prescribing medications. And obviously, a lot of the psychotropic medications have a lot of side effects, as you know. But for medications other than that, I would say, statins, blood pressure medications, we prescribe quite commonly. We usually don't have issues prescribing those unless obviously, someone's very frail or they have orthostatic hypotension, then we try to avoid prescribing antihypertensives. Things like aspirin, if there's, clear previous coronary artery disease or strokes, we recommend prescribing those. Other than that, I mean, are you referring mainly to medications other than the psych medications?
Yeah,
Yeah,
exactly. Yeah.
Yeah. Diabetes, like we prescribe a lot of metformin, diabetes medications as well, usually targeting an HbA1c. It really depends on the patient, but when they're more functionally dependent and frail, we say the target is around 8 to 8.5 at that point. So if they have an HbA1c much higher than that, then usually metformin will be a medication that we'll prescribe. And I recommend prescribing that as well, just to be careful about any GI side effects with that. Yeah, I think any of the sort of vascular risk factor management sort of types of medications, I would recommend doing.
Thank you. Any other questions?
I was wondering when you take somebody off of a statin, because sometimes we see older adults who are like 94, pretty frail. They're on a bunch of medications. And I guess I'm kind of wondering, when you're looking at which medications could we take away, like when is it okay to consider taking away a statin?
Yeah, I would say because the sort of point of a statin is preventing sort of, atherosclerosis over the long term. Once a patient is sort of 85 years old and older at that point, and there's already considerable polypharmacy, a lot of geriatricians will consider deprescribing the statin at that point. Because at that point, the benefit, there's really not much of a benefit in terms of the longitudinal.
Are there any other medications kind of like that you can think of that you tend to deprescribe in sort of older adults? Because I guess just the thing is that sometimes we have an older adult who is really quite clearly depressed, and that's sort of an immediate threat to their well-being and their quality of life. But they're on a lot of other medications, and so even just being able to recommend to a GP to look at deprescribing, like maybe a statin is one of them, or there are other ones that people are commonly on?
Statin is one of them for sure. Once you start getting, 85 years old and older, I think a lot of people are on aspirin sort of unnecessarily because it used to be given in the context of primary prevention, but it's not really the recommendation anymore. It's usually now once you actually have, proven coronary artery disease or previous stroke. So a lot of the times aspirin, you can look into whether or not there's an actual indication for it. And a lot of cases we found, okay, this person doesn't really need aspirin. I think the diabetes medications as well, it's one that I suggested you also prescribe, but in a lot of cases, you'll see somebody on like 3 diabetes medications and their HbA1c is like 6, or, you know, something super low, like definitely below 7 or even below 8. And at that point, they don't need to be that controlled. The guidelines say, you know, around 8 if you're functionally dependent, and if you're very frail with a risk of hypoglycemia and falls, and even under 8.5. So you can likely take away diabetes medications depending on how controlled they are. What else? Like Pantoloc is another one that people are sort of on unnecessarily. They've had GERD at some point, or, you know, they were on an NSAID and then the Pantoloc just was left on. So that's a medication you can sort of look into whether or not they actually need it. And if there's a clear indication, like GERD or previous peptic ulcer disease, or they're on a medication that requires a PPI, but if not, then it can probably be removed. Yeah, those are the main ones that are sort of coming to mind. Yeah, those are the main ones that are coming to mind.
That's really helpful. Thank you.
Thank you so much for this lecture. Number one, I really hope that we could have your slides, because I just feel like I want all of these available on my phone at all times for my
Sure, I have no problem.
And then number two, so depending on where we work, like Dr. Hickey was mentioning, we might be in these rural areas where someone doesn't have access to a geriatrician, and I'm working on kind of expanding my comfort with my medical scope of practice outside of psychiatry to provide those services. Do you have like a recommendation on where to find the most up-to-date guidelines? Like, is there Canadian Geriatric Society kind of compendium?
Yeah. For the more medical things, you mean? Like for diabetes would be the Diabetes Canada guidelines. There's also the Hypertension Canada guidelines, and they have like quick few page PDFs. So we'll give you sort of the highlight for each cutoff, both for Hypertension, Diabetes Canada. Osteoporosis Canada is coming out with new guidelines, should be like in 2023, and they also have a super quick, like just a 10-page highlight PDF for all the little cutoffs, and that might be good to look at. And like, okay, when should a person be screened with a bone mineral density to sort of start that fracture risk assessment rolling. Otherwise, in terms of guidelines for medical stuff, I think those are the most ones, because I think like vascular risk management can be useful for you guys, especially in the context of like, you know, dementia and dementia prevention and managing that. But CGS, if you take a look at the Canadian Geriatric Society, they'll also have a lot of medical overviews there, like review articles. So that might be a good place to take a look. And AGS as well, the American Geriatric Society.
Thank you so much.
No problem.
Any other questions? I would have to agree, of all the presentations we've had thus far this year, I feel that having these slides for our residents is such a huge resource. You covered so much in such a succinct fashion. And in my mind, you kind of tailored it to what a geriatric psychiatrist should know, which is so hugely helpful. So yeah, if you wouldn't mind emailing the slides, I don't know if do you have my email address, Carolyn?
I do. Yeah.
Yeah. So if you could just send that to me, that would be great. And we will upload those for you guys, hopefully in the next week or so. And we will also upload the presentation, the recording. And any other questions? We might have a couple minutes left, but if there's no questions, we can sign off. Okay, so rest assured, your supervisor will be getting an email from me saying how hugely helpful this was.
You're nice.
Thank you for taking this on. It was quite amazing. And we wish you well, and hopefully we'll see you sometime soon in the future at I don't know, a CAGP maybe. Hopefully you'll come and share your knowledge, and your passion for caring for older adults was obvious, and I think we all share it. And have a great day, everybody.
Have a great day, guys. Thank you. Bye.
Bye.